I think with that, we'll probably move on to our final set of speakers. We have Drs. Barb King and Linsey Steege from the UW-Madison School of Nursing, and Shelly VanDenBergh, who's a clinical nurse specialist with UW Health. I'd also like to recognize the large contingent of nursing students who you guys rolled deep, so thanks for coming today. Our final team will discuss Move-In, which is a nurse-led intervention to maintain mobility in the hospital setting. So thanks very much.
Us to present as part of this panel today. In hospital settings, 1 in 5 older adults will fall at least once during their hospital stay. And of those individuals who fall, at least 30% will incur some type of an injury, being either a major or a minor injury. Now, falls in hospitals are somewhat complex. Not only are they related to the physiologic effect of the acute illness, but also the occurrence of acute onset confusion that can occur during a hospital stay, gait instability that often happens, and the fact that an older adult is now in an unfamiliar environment. Due to the complexity of the hospital environment and the complexity of falls itself in hospitalized patients, interventions that have been successful, like Moving On, that we see in the community, and even what's been done in long-term care, do not necessarily translate to a hospital environment. So that we don't really have a whole lot that we can grab from, to borrow from, and to use in our settings. Further research of falls in hospitals is really very much in its infancy. And of the studies that have been conducted, those that use multi-strategy approaches have been shown to be most promising, and of those, only a 20% reduction in falls has occurred. So currently, we have no evidence-based practice guidelines that will help hospital administrators or nursing staff into trying to come up with a strategy to prevent falls or reduce falls during a patient's hospital stay. So in 2008, the Center for Medicaid and Medicare Services enacted Never events. And the Never events were put in place to align care quality with the financial incentive. Never events are high-cost, high-volume events that should be preventable with the use of evidence-based practice guidelines. Falls with injury are one of those 8 Never events. And under the Never events, a hospital can no longer justify charging a higher level Medicare DRG to recover the costs that occur when a fall happens in their system. But a recent impact study that was done on the Never events showed that the CMS non-payment policy has had no impact at all on falls in hospital settings. Now, we know that falls are increasingly being used to judge quality of care in our hospitals. Particularly, this is true for older adult patients. And across the country, many nurses are now reporting that the message they receive is that they are to have 0 falls within their hospital system. Nurses also report that they're getting increasing pressure to maintain that 0 fall goal. And without having any type of evidence-based practice guidelines to guide their care, unfortunately, many nurses report that they use limiting patient mobility as a strategy to achieve no falls within their hospital system. So we wanted to tackle this issue of mobility within hospitals, and just a few statistics on what actually happens. Up to 65% of hospitalized older adults will lose functional independence during their hospital stay. Now, that can be as simple as losing their ability to do a basic activity of daily living, but more concerning, losing their ability to independently ambulate during their hospital stay. When we looked at ambulation, this has actually been identified as a hospital-associated disability in the literature. So many researchers have looked at, well, how often are patients actually walking during their hospital stay? And those researchers have used research-grade accelerometers to measure ambulation frequency and distance and time. And what we've discovered is that 96% of the time, patients are not engaged in any ambulation. Other researchers have shown that 83% of the time, patients spend their time lying in bed. The other more concerning factor is that we've now been able to identify that this limited ambulation and extensive bed rest is the most preventable and predictable cause of the hospital-associated disability that occurs in an older adult patient. So what happens when we put patients in bed and we don't let them move? And this is particularly true for an older adult. The most biggest issue is that there's a loss of muscle mass and strength that occurs in the lower extremity, up to 3% per day. So 10% loss of strength and mass is pretty much the breaking point for somebody being able to go home and live independently in our community setting. We also know that fainting or the sensation of feeling dizzy often occurs with bed rest, and that's due to a shift of plasma volume within the central circulation. Confusion commonly occurs with limited mobility in bed rest. Secretions pool in the lungs, so we see more incidents of pneumonias that occur, and also a decrease in the ability of the lungs to oxygenate. All of these factors lead to falls. So although a fall may not be happening in the hospital because we're not moving patients, Jane, you're going to see the falls, unfortunately, in community settings. So sometimes that fall just gets transferred to another setting, and we're putting our patients more at risk. More concerning is that these consequences occur within 48 hours of bed rest. So it doesn't take very long for this to happen to an older adult. Now, you would think it would be easy just to get a patient up to walk during their hospital stay, but actually getting patients up to walk is really quite complex. And there's multiple barriers that occur within a hospital system that have a direct impact on the nurse's ability to get a patient up and moving. Often nurses describe that they have limited resources. So they don't have the walking devices readily available on their inpatient unit so that the patient is available, I'm available, let's go for a walk, there's no walker here. So it takes time to get that device. Or they just not enough physical assistance to help getting patients up to walk. Another barrier is that there's poor communication amongst healthcare providers in terms of how often patients should walk, how far patients can walk, how much assistance do they need. Further, we have a culture within our across the United States now that organizations are prioritizing patient falls over promoting patient mobility. Patients also report that they experience multiple barriers. Many times they feel they cannot ask nurses to get them up to walk. They feel nurses are too busy, or that's not something that they should be doing. Often patients are alarmed with motion alarms that keep them in place. So the alarm goes off, I'm not supposed to move, or I'm supposed to wait until someone can come to help me. And then nurses themselves experience personal barriers. Many nurses describe a fear of falls, or the fear of the repercussion that will occur if their patient falls during their care. Also, nurses feel unprepared in order to make that determination. Can this patient safely ambulate? And then how do I progress this patient?
So as Barb mentioned, she talked a lot about the challenge and the depiction of the problems and the importance of mobility in the hospital setting. And I'm going to talk a little bit about how we then developed an intervention to address these and to help overcome many of these barriers that Barb just described. So this is a complex problem, and one of the limitations of prior interventions in this area and other areas in healthcare is that they essentially are add-ons. So we're asking healthcare providers, healthcare workers to just do more without really thinking about removing those barriers that get in their way of best practice or practicing the way that they know they should in these settings. So that's where our partnership initiated, and that Barb is a nurse and a nurse researcher, and I am a systems engineer with a background in human factors. And human factors is the discipline that focuses on the design of systems or things for people. So how do we make everything work better for us as humans and what we need to perform rather than expecting us to adapt? So if you translate that to this context into healthcare, rather than asking the nurses to just take on more and find a way to make this work, how do we build the system around them and think about all of the pieces that are needed to enable them to get their patients up and walking, and then us to hopefully see those long-term improved patient outcomes, and in a way that's sustainable. So it would be able to continue after we went away and we're not there supporting the nurses in this anymore. So we used what's a well-known human factors and systems model to really guide how we design this intervention. And it's shown here. It's the Systems Engineering Initiative for Patient Safety model. And on the left, you see that it defines explicitly the different elements of a work system that you really need to think about. So the person, in this case, the nurse who we're asking to get these patients up and walking, is in the center. And we need to account for his or her biases, self-efficacy, confidence, knowledge, and then understand what tools and technology are available or not, what tasks they're being asked to do besides ambulation, what is the organization, this messaging around falls, that sort of culture, how do you account for that, and then also the physical environment and whether or not it's designed to support this activity. All of those elements work together to hopefully carry out care processes, again, in this case, hopefully ambulation, and achieve positive patient outcomes, but also positive outcomes for healthcare staff and the organization in terms of cost. So we used this model and the prior work that Barb described on what are the barriers that nurses experience and that the system has in place to patient ambulation, and designed an intervention that really had multiple components that span the system and aim to remove the barriers and then provide nurses with the resources they need for ambulation. So we had 5 components to this program. We began with the nurses themselves and provided a training program to really give them the skills and the competence that they need for engaging older adults in ambulation, and we worked with physical therapy to help provide that training. We also provided additional resources to these units in terms of having readily accessible assistive devices such as walkers or gait belts, and then also the hiring of 1 additional nursing assistant as a mobility aid for that unit. We added some work, some engagement artwork to the unit. We called it the Walk Around Wisconsin Pathway. So we put up visual art as a sort of cues to help the staff and the patients in ambulation pathways, as well as physical markers on the floor to allow for better tracking of distance that would support nurses in really understanding whether or not patients were progressing. So we're getting them up and we're helping really build that functional capacity rather than just losing it, as Barb noted. We looked at communication, so how we were changing how staff communicate around ambulation, making it forefront. So when they did their shift handoffs, how many times has this patient walked today? How far can they walk? What do they need? Also visible cues to both the patients, their family members, and the staff around the importance of ambulation. And then we really looked at the unit culture and, again, trying to sort of counteract and facilitate positive messages around ambulation rather than the more punitive false messaging that many staff reported. And again, the goal was to increase ambulation and look at ultimately improved health, reduced costs, and increased patient experience. And this is just a brief illustration to break up the slides a little bit here of the Walk Around Wisconsin Pathway. As you can see, the ambulation aid and a patient looking at some photos on the wall. We did have during the intervention period, the staff walked the patients far enough that they made it to Chicago by distance that we were tracking, so we gave some deep dish pizza to the staff during the intervention period. And then again, we had a change we created communication boards that were up in every patient room that really focused on ambulation as a priority.
And I will speak from the clinical side of working on the unit that we initiated this research on, and that's a hospital medicine unit at University Hospital. So we looked at what this actually, attacking all of these system barriers, what happened to the number of times that our patients walked, and how far did they actually go. So we looked at data for 10 weeks prior to the intervention phase, and you can see that in the slides here that the distance from prior to the research study definitely increased during the study, as well as the occurrences. And then for the 13 weeks post-intervention, what happened when the study team moved away. And you can see that we sustained that change. So this was approximately 2.5 years ago that we performed this research study. And looking further, I will speak more as well about how that has gone now, today, 2.5 years later. But first, some patient feedback. So patients provided us lots of positive feedback, too, throughout this research about what they thought about this program and the way that we are attacking these system barriers. Patients really like the My Activity board in their room. It provided a visual tool to them and provided some instant gratification when they could see, oh, look, I got all my boxes checked off for the day, and I walked this far, and I was up in the chair for this long, and it allowed for them to see a visual management tool of how were they progressing in their ambulation. also, like Barb talked about, patients feel like they're burdening staff when they call to go for a walk. So just having them vegetate in their bed, obviously the literature shows us that that increases falls long term, and so having the nurses really motivate the patients, along with having that visual tool to help motivate the patients, was helpful. We actually even saw some increases in functional ability of our patients. One patient had commented that she was able to walk further than when she came in the hospital. So when she came into the hospital, her first walk, she was only able to walk 50 feet, and prior to coming into the hospital, that was her limit. And then leaving the hospital, she was able to walk 200 feet. So seeing significant improvements was sort of over the top of what we expected to find. We were hoping to prevent the functional decline, but we didn't expect to necessarily see those efforts go up in that way. And then the pictures around the unit motivated the patients as well. So we were able to receive a grant for those beautiful pictures. And with the theme of Wisconsin, walk around Wisconsin, the staff really liked the pictures as well. I just had actually a guest comment on them recently. And then it also motivates patients at the same time. So, last time you made it to the Capitol photo, which is a beautiful photo of the Capitol in a sunset. Next time, let's see if we can make it to Camp Randall. And I actually even had a patient comment that there was someone in the picture of Camp Randall that they thought they might know based on the seat location. So fun there. And then, like I said, 2.5 years later, where does this bring us in terms of the number of times our patients are walking a month and the distance that they've traveled? So you can see here, October 14th was where this graph started, and that provided a little bit of pre-data for us on the number of ambulation occurrences in the green line, and then the miles ambulated with the orange bars, and where we started, and then the intervention phase in March through May of 2015. And you can see how those efforts have sustained or even improved since that research study. So that really showed us on the unit too, that as the research team fizzled away to their next projects and disseminating this literature, that we were able to sustain these changes. And I think that was totally targeted by those system interventions. The staff are even taking it one step further. Yesterday in a council meeting, they asked me if they could receive data on their own personal performance, and they're a little competitive, so they would like to see theirs compared to everyone else's. And of course, they love incentives too, so they had talked about having like a monthly competition to see who can walk the patients the furthest and the most. It's also easy to looking at this data to assume that just targeting our ambulation aide, who is an extra resource, the nursing assistant who jumped in to prioritize patient ambulation, could this all be a result of her and her priorities with ambulating patients? And we actually are able to separate that out in the data that we receive. And that shows us that on average, the ambulation aide's work accounts for only 15% of the ambulation occurrences on the unit, while it accounts for 40% of the distance. So she might be able to push patients a little bit further and take them farther because she has a little bit more time, but yet at the same time, her work is only accounting for approximately 15% of the actual occurrences of ambulation on the unit.
So in our summary, the Centers for Medicare and Medicaid Services in their final rule noted that they did not have specific guidelines for fall prevention, but look forward to working with the Centers for Disease Control and with the public to start identifying research to assist hospitals. Now, as you can imagine, there's many researchers and clinicians across the country that do mobility and fall research that have raised concerns. And the concerns have been, is CMS relying on penalties to drive science, rather than relying on existing science to support improvements in healthcare delivery in our hospital systems? So given the current policy on never events in hospitals related to falls, there is mounting concerns that we are now experiencing unintended consequences of policies that have been put in place regarding that could affect mobility, especially for older adults during their hospital stay. The other concern is that only accounting the number of falls does not equate with quality of care. And there are many researchers and clinicians across the country that are now sounding the alarm that if we see 0 falls being reported from hospitals, we should be very suspicious of what's happening with mobilities within those systems. Losing the ability to independently ambulate, I think all of us in aging would agree that that's a serious and significant public health concern that largely goes unnoticed and unattended to in our hospital systems. So rather than counting the number of falls that occur, I think we need a shift in our performance metrics. More importantly, we should be looking at these functional performance measures. How far can a patient walk? How well can a patient walk? How independently are in their functional ability, not only during their hospital stay, but once they're able to go home, into wherever home may be, as a better measure of the quality of care that we can provide in our hospitals. So finally, hospitals are complex. It's challenging to do research in hospitals. It's challenging to do complicated research such like this in a hospital system. So as Linsey had indicated, just telling nurses they need to walk patients more is not going to be the answer. We demonstrated that we had to knock down barriers first in order to get nurses secure enough and have their time freed up enough and resources available to them that they could get patients up to walk. And by using a systems-based model, we were able to demonstrate a meaningful and sustainable measure of quality of care. Thank you.
Well, thanks for that presentation. And we'll end with any questions from the audience or on this. I'll start off with a quick question on, obviously we're in the state capitol, we have legislators, legislative staff in the room, but public policy is only one part of this. So in terms of the private sector policy that's made every day in the hospitals, what would you say from your experience is the low-hanging fruit in terms of barriers? And whether it's culture shift or whether it's the barrier, what can a first step be on the private sector side?
Oh, that's a really good question. If we can't shift culture, putting all of these other Band-Aids in place probably isn't going to be as sufficient. So as we indicated, just putting a mobility person in place most likely won't make a substantial impact. So this shift towards we can't have any falls and we're going to get penalized if we have falls is somewhat dangerous right now in our hospital systems. And we are seeing that across the country. So it's changing our priorities. Instead of we can't have any falls, it's are we safely ambulating patients? Are patients getting up? And is that should be the quality metric that we should be targeting, along with patient satisfaction. I have to believe that patients are going to be far more satisfied that they get to go home and they're independent rather than I have to go to a nursing home and do rehabilitation and I don't know if I'll get out of that nursing home. So that's, I think, our big push right now is shifting how we're talking about mobility in hospitals and then changing the fear factor. Instead of everyone's going to fall to, well, let's get them walking. What would it look like if everybody walked?
Hi, I'm Betsy Abramson, and I'm the director of the Wisconsin Institute for Healthy Aging that Dr. Mahoney and others have mentioned. I just wanted to say, particularly for the benefit of Representative Petrick and Representative Reamer, that as was mentioned, we do have the Stepping On program in 66 counties. And this past year, over 200 workshops were held throughout Wisconsin. And we're eager to work with the legislature in how we can expand that. As Barb mentioned, Brown County is one of our superstar counties, but when she mentioned the number of folks, and I did the math while you were talking, Barb, that's less than 4% of your population. So as she said, 1,700 is great, but it's nowhere near the 43,000 older folks that we need. And then I just wanted to put a face on what our nurses were talking about now as well. As my friends here in the audience here, I always bring up my own mother, who was just in UW hospital with pneumonia last week. And I do find it ironic that she came in there, probably in part got pneumonia from so much sitting at home. Got there, and she was all wired up. Every time she tried to move, all the buzzers went off. And there was a leaf on her door, signaling she could fall like leaves. And they barely let her move the whole time she was in pneumonia. And in a hospital, of course, as she left, escorted her all the way to the curb in the wheelchair. And my mom wanted to stay in the hospital a day or two longer than I think was necessary because she was worried about how she'd ambulate at falls and thought she needed more rest. And I said, no, you need more ambulation and to get going again. And that idea of putting them in a protective bubble, whether at home, I mean, we find people who take stepping on are, of course, moving more and are less isolated now because of the experience of doing the strength and balance exercises, having a better handle on their medication, having more control over their environment, and practicing all that and implementing it all through the work that they do in stepping on is what makes the difference. Keeping older people in bubbles, and I see that when I see my younger friends in hospitals, they're up and moving. The older people we keep all guarded around, and keeping people in that bubble does not help them when they get home. So we'd be happy to work with you.
And with those final comments, I think we'll bring today's program to a close. If you haven't done so, please fill out your evaluation forms and leave them on the table on your way out. Again, all materials and program video will be posted on our website and emailed out to everyone here today. So if you want to leave your email address on your way out, make sure you do that. Also keep an eye on our website for upcoming programming. We are looking to do additional programming related to aging, social determinants of health, and healthcare workforce. Thanks to legislators and their staff who are in attendance today, Representative Reamer and Representative Petrick, and to our panelists for your great work and for your participation today. Thanks much for this ongoing dialogue between the campus, Capitol, and the community, and we will see you next time. Thanks.